Hello everyone, and welcome back to our program on human microbiome and dysbiosis in clinical disease. Today we're going to focus in on cutaneous and environmental dysbiosis. We're going to look at microbes, we're going to look at specific diseases, and of course we're going to focus in on the clinical actions that we can take. We'll do that for cutaneous dysbiosis, and of course then we'll do it again for environmental dysbiosis. As always, we're focusing in on what's actionable and clinically relevant. We're not just having a philosophical conversation about microbes and dysbiosis. No, we are focusing on clinical relevance here. This is the article that I published in 2006. You're welcome to download that from academia.edu. That provides kind of an overview of many of my original ideas back in 2006. And really, I certainly haven't changed those ideas. Of course, I've built upon them, but I haven't discarded any of those ideas from 10 years ago. Today we're going to focus on cutaneous dysbiosis-induced disease, and again, clinical actions that we can take. In this conversation, Staphylococcus aureus clearly is the main player, and I think we can say that without any doubt. Disease associations or disease causations include eczema, atopic dermatitis, and type 2 diabetes, and specifically insulin resistance. What we can do about this is disinfect the nares. We talked about that previously in the presentation on cynorespiratory dysbiosis. And we can also disinfect the skin. I've covered that in the book, and we'll also, of course, talk about it here today. Obviously, we need to address immune defenses and immune tolerance anytime we're dealing with a microbe-induced inflammatory disorder. Following the conversation on cutaneous dysbiosis, I will, of course, review the same template as applied to environmental dysbiosis. Cutaneous dysbiosis, disease examples are atopic dermatitis and the resultant bacterial allergy that I detailed in the book. This bacterial allergy occurs via IgE and histamine, and I think it's a classic example of bacterial allergy, again, that I detailed and kind of built that paradigm within the accompanying clinical monograph that you have. For objective laboratory assessments, we can use cultures of the skin and nares. We can use serologic tests. We can use DNA-based testing for microbes as well. Treatment considerations where we have really clear evidence in the treatment of cutaneous dysbiosis, specifically with regard to atopic dermatitis. We can use antimicrobials such as 5% povidone iodine, mupirocin, which is an antibiotic ointment, cephalexin, which is an internally ingested or orally ingested antibiotic, and we can use the bleach baths that I've reviewed with you previously, also in the book, and also, of course, I'll review that again in this presentation. We can promote immune tolerance with omega-3 fatty acids, vitamin D, etc. Let's look at this article from Pediatrics 2009, Treatment of Staphylococcus aureus colonization in atopic dermatitis decreases disease severity. This was an excellent article. Several articles have been published on the same theme, showing that if we decolonize or decontaminate these patients from their abundant overgrowth of Staphylococcus aureus, that improves their disease status, and of course that also therefore proves the model of cutaneous dysbiosis in these patients. Conclusions that you can see, which I've highlighted here: chronic use, or repeated use, they should say, repeated use of dilute bleach baths with intermittent intranasal applications of mupirocin ointment decrease the clinical severity of atopic dermatitis in patients with clinical signs of secondary bacterial infections. Those secondary bacterial infections are not necessary for implementation of this treatment. Patients with atopic dermatitis do not seem to have increased susceptibility to infection or colonization with resistant strains of Staphylococcus aureus. So basically what they're emphasizing with that last statement is that these patients simply have quantitatively more bacteria on their skin. What we see in other conditions such as psoriasis and diabetes is that the patients not simply have more bacteria, but they have more pathogenic strains of those bacteria. So what we see in atopic dermatitis is a quantitative issue, and what we see in psoriasis and diabetes is a quantitative and qualitative issue. The qualitative issue being that the bacteria that colonize those patients are actually more pathogenic, or what we might say, more aggressive. So here's my summary slide for our treatments and interventions for cutaneous dysbiosis, specifically in this case as applied to atopic dermatitis. We're specifically concerned about Staphylococcus aureus on the skin. it's seeded to the skin from the nares, and again from the skin back to the nares. So I told you previously that we have to break that cycle of nasal colonization and skin colonization. So when you think of treating the skin, you want to think of the internal nares right inside the nostril. You want to think of that obviously as simply an extension of the skin. That's where these bacteria kind of congregate and establish a base, we might say, or a foothold. So even if we were to apply skin hygiene, home and workplace hygiene, for example, we would still need to apply that same hygiene protocol to the inside of the nares, because we can consider that to be kind of a hiding place for these bacteria. Diseases, atopic dermatitis patients have allergy to Staphylococcus aureus. Our assessments can include swab and culture of the skin and nares, and sinuses can also be performed, or we could simply use empiric treatment. Most studies have used simple empiric treatment without the need for extensive laboratory assessment and culturing of samples. Treatment, again, is generally empiric. Response to treatment is what is most important, and a positive response is retrospectively diagnostic. Our treatment considerations are antimicrobial agents. We can use various drugs, antibiotics, such as cephalexin. We can use mupirocin ointment. We can use the dilute bleach baths, which I've reviewed previously and will review again here today. We can use 5% povidone iodine because that's actually more effective than topical mupirocin. It's obviously less expensive and more widely available as well. For hygiene, we want to focus on using nasal lavage, dilute bleach baths again, house cleaning, eliminating microbes, and what I tell patients is that they also need to have a set of sheets that they can bleach along with their towels, for example. But we have to think about these kids typically with eczema, also adults, of course, but when their clothes are seeded with these bacteria and their sheets and towels are seeded with these bacteria, we need to clean the entire environment. So at the very least, we need to wash linens and clothes in very hot water, and if we can apply bleach to them, all the better for disinfecting them of these bacteria. For immunonutrition, we focus on zinc, vitamin A, vitamin D, and combination fatty acid therapy. I abbreviate that as CFAT. I talked to you previously about kind of decolonizing or decontaminating the nares. We can use 5% povidone iodine. As you can see here, this is a product available from 3M. Obviously, you could make your own povidone iodine at a 5% concentration. Typically, what you buy in the stores is a 10% concentration. So you could simply dilute that with distilled water, for example, and assume reasonably that you're getting pretty close to a 5% concentration of povidone iodine. As you can see here in the product description, this is a 2-minute application, typically non-irritating. Within 1 hour, reduces Staphylococcus aureus by 99.5%, 12-hour persistence, and no antibiotic resistance against povidone iodine. And we can't say the same thing about mupirocin. Some bacteria are resistant to mupirocin. So-called antibiotic resistance against iodine is unheard of. Same product here, just in a larger image so you can see some of the details. Breakthrough technology from 3M kills 99.5% of Staphylococcus aureus in the nares in just 1 hour. That's again with an application of 5% povidone iodine. So it's also used not only for cardiothoracic surgery, but also for orthopedic surgery, of course. So a lot of these surgical infections, surgical complications have been traced back to bacteria residing in the nares, seeding the skin, as I say, and then creating these postoperative infections. Let's look at a few more details here. Sinorespiratory dysbiosis with Staphylococcus aureus seeds the skin for an allergic inflammatory response in atopic dermatitis. Let's look at this article from Immunology. This was 1992. Effect of Staphylococcus aureus cell wall products, teichoic acid, peptidoglycan, on immunoglobulin synthesis in patients with atopic dermatitis. And you can see in the second quote that I highlighted, co-stimulation of peripheral blood lymphocytes with teichoic acid or peptidoglycan led to a pronounced increase in IgE synthesis in patients with atopic dermatitis. So again, my model, we might say, of atopic dermatitis is that it is fundamentally an allergy, a bacterial allergy directed against Staphylococcus aureus on the skin. I think the current research bears out that model very well. Let's take a look at this article, Management of Atopic Dermatitis in the Pediatric Population. This was published in 2008 in the journal Pediatrics. Sudden exacerbations of atopic dermatitis attributable to overgrowth of Staphylococcus aureus can be independent of a true secondary bacterial infection. Honey-colored crusting, folliculitis, and pyoderma are signs of overt infection, and topical and/or oral antibiotic therapy, typically of short duration to avoid the development of bacterial resistance, is indicated. Toward the bottom of this excerpt, diluted bleach baths, analogous to swimming in a chlorinated pool, are an adjuvant anti-infective treatment that can help decrease the number of local skin infections and reduce the need for systemic antibiotics for patients with atopic dermatitis with heavily colonized and/or super-infected skin. Let's look here at their bleach bath primer. Obviously very important to follow instructions, so let's review these here. Add lukewarm water to fill the tub completely, approximately 40 US gallons of water. Depending on the size of the tub or the amount of water used, add 1/4 to 1/2 cup of common household bleach to the bath water. Obviously you want to mix that in and stir it quite well so it's not concentrated at the surface or in a specific location. Stir the mixture to ensure that the bleach is completely diluted in bath water. Have patients soak in the chlorinated water for 5 to 10 minutes. Thoroughly rinse the skin clear. As soon as the bath is over, pat the patient dry. Do not rub dry, as this is the same as scratching and would create an opportunity for a skin infection by breaching that dermal surface. Immediately apply any prescribed medications or emollients. Repeat the bleach baths 2 to 3 times per week or as prescribed by the physician. Obviously, we want to follow these restrictions. Do not use undiluted bleach directly on the skin. Do not use bleach baths if there are any breaks or open areas in the skin. And of course, do not use bleach baths in patients with a known contact allergy to chlorine. I showed you this case previously of a severe chemical burn in a patient who was advised to use a bleach bath for her atopic dermatitis eczema. So this underscores again the need for clear and written instruction. This patient apparently applied concentrated undiluted bleach directly to her skin, and of course you can expect that that would result in some medical legal complications. The following article talks about the role of superantigens in atopic dermatitis. The source of those superantigens is mostly Staphylococcus aureus, and you can see the effect on IgE, increased production of IgE antibodies, high serum level of staphylococcal superantigen specific IgE antibodies in these patients with atopic dermatitis. So again, I describe this as a bacterial allergy in these patients with atopic dermatitis, and that bacterial allergy is directed against Staphylococcus aureus. 30 to 80% of atopic dermatitis patients also show IgE or T-cell reactivity to yeast. Obviously, using the dilute bleach baths that we've covered now several times would be effective against the yeast as well. So again, here in summary, atopic dermatitis, allergic dermal dysbiosis to bacteria as well as yeast. So we don't want to necessarily rely on drug antibiotics when we could use a broader spectrum program that also includes targeting the yeast on the skin, not simply the bacteria, but also promoting healthy barriers and healthy immune defense. Again, vitamin D, zinc, vitamin A, and combination fatty acid therapy. Let's briefly look at this article from Journal of Dermatology 2013, Efficacy and Safety of Sodium Hypochlorite Bleach Baths in Patients with Moderate to Severe Atopic Dermatitis. Patients soaked in dilute bleach for 10 minutes twice a week for 2 months. Patients in the treatment group showed significant reductions in the eczema area and severity index. A 42% reduction in Staphylococcus aureus density from baseline was seen at 1 month, further reducing to 53% at 2 months. Equal numbers of patients in both groups, that is the treatment group with the dilute bleach baths as well as the distilled water group, both experienced mild side effects. So obviously not too much to be concerned about if the adverse effect of dilute bleach are comparable to distilled water. I showed you this article now several times, the role of microorganisms in psoriasis. We could use many of these techniques for different diseases, obviously in this context including psoriasis, atopic dermatitis, and our next topic, which will be insulin resistance and diabetes. So again, for the microbiology assessment, we can use certain stains, we can use certain cultures, we can use serologic testing. But again, a lot of the treatments that are represented in the clinical studies are based on empiric treatment based on the clinical diagnosis. So for example, simply a diagnosis of psoriasis, simply a diagnosis of atopic dermatitis. They don't do microbiologic assessment in these patients. They simply look at the research that's already been published, establishing the relationship, and then they treat based on that relationship that's already been established. And the results of that type of empiric treatment are quite good. I showed you this study previously from European Journal of Dermatology 2005, long-term use of penicillin for the empiric treatment of psoriasis. So again, here the presumption is that these patients have some type of microbial colonization, specifically with Streptococcus pyogenes. These patients are treated empirically with penicillin, and they show excellent response to monotherapy with penicillin-based antibiotics. So in summary, let's look at what we can do using atopic dermatitis as a model of dermal dysbiosis. So I'm not saying that this would apply only to atopic dermatitis. You could use a similar approach for diabetes. We're going to look at that in just a moment. You could use a similar approach for some cases of psoriasis as well. So we're going to use this atopic dermatitis protocol as kind of a foundational or referential protocol, we might say, against dermal dysbiosis, because atopic dermatitis is the model condition of dermal dysbiosis. You can use swab and culture if you want to do some type of objective laboratory assessment. Again, if you're looking for specific microbes, you can also do serologic testing, or you could just dive into empiric treatment. Among the options from which you can choose for empiric treatment, you can use cephalexin if you want to use antibiotics systemically. Obviously, that's going to have consequences for the GI microbiome. You can use mupirocin ointment. I think that 5% povidone iodine is more effective, less expensive, and more widely available. Obviously, we all have access to using the dilute bleach recipe that I showed you previously. For hygiene in general, we want to use the nasal lavage. Again, dilute bleach baths, house cleaning, eliminating the microbes from the sheets, the towels, and the clothes. So we can bleach wash the towels and the sheets. And what I described here, just as I was putting these notes together in their final version, a rotation diet for your clothes. So we don't want to have patients wearing the same clothes day in, day out, and recontaminating themselves as we're trying to rid them of their dermal colonization. Of course, immunonutrition and immunotolerance, zinc, vitamin A, vitamin D, combination fatty acids, and probiotics. Now let's stay on the topic of dermal dysbiosis and see if we can apply this information to type 2 diabetes and insulin resistance. So what I'm going to do here is just go through a stepwise process, of course. We're going to look at facts, we're going to look at an emerging model, we're going to look at some specifics, we're going to look at the mechanism, and then I'll show you again some of the research that we've looked at before. So the fact is, patients with increased body mass index, which correlates with obesity, have more skin and therefore more surface. So whatever's happening in or on that surface is going to become more relevant, even if those events are invisible. One emerging model is that increased skin surface area might allow for increased absorption of microbial products that have metabolic effects, specifically inflammatory effects that eventually lead to insulin resistance, and that of course feeds the obesity and diabetes cycle. Going into more specifics, we see that people with obesity have more surface area, and that people, of course, with diabetes are immunosuppressed. So they have more quantity of bacteria, and they have a more aggressive quality of the Staphylococcus aureus on their skin. So it's kind of a double hit. They have more bacteria, and they have more aggressive bacteria, perhaps due to the fact that they're immune suppressed. So the pathophysiologic molecular mechanism that we're looking at here is that superantigen from Staphylococcus aureus gets absorbed through the skin to promote direct inflammation as a superantigen, but it also impairs clearance of endotoxin from gut-originated bacteria. And this results in what we can call superinflammation, leading to insulin resistance. So now that we've said that, and we've kind of proposed the model, let's take another look at the supporting data. This is just a press release, a popular article in Economic Times. This is obviously not a medical reference, but I wanted to use it because it kind of breaks down the research into easily understood and explainable language. Title of this from June of 2015 is Bacteria May Give You Type 2 Diabetes. So I'm just going to read to you some highlights and quotes from the authors. Prolonged exposure to a toxin produced by Staphylococcus aureus bacteria causes rabbits to develop the hallmark symptoms of type 2 diabetes, including insulin resistance, glucose intolerance, and systemic inflammation. We basically reproduced type 2 diabetes in rabbits simply through chronic exposure to the Staphylococcus aureus superantigen. Moving down now to the lower part of the page, the authors state, what we are finding is